So a few disclaimers. David made the program, so he gets to choose his side. And I was roped into this 3 weeks ago. So, and my ultimate goal is, I think the pre-survey results for Howard were similar, like 25%.
Yeah.
And then he went to 0. So if one person can keep a yes, that would be great. So I'm going to probably repeat most of the slides you saw because the last 3 talks were very similar to some degree or to a lot of degree. So, one answer to the question is because David says so, because the NCCN guidelines, of which he's on the panel, as well as others in the room, still have epirubicin in their guidelines. So I'm not just focusing on metastatic disease because the actual topic didn't say focus on metastatic, that I'll do several on metastatic. So this is the ones I listed here for the gastric cancer. Esophageal and G junction are similar for metastatic disease, where if you look at category 1 choices of therapy for perioperative therapy, ECF, the various modifications, 5-FU and cisplatin are in the perioperative, and then for first-line therapy, 6 choices to consider, including the variations of docetaxel platinum, fluoropyrimidine regimens, and the ECF regimens. So again, the wisdom of the NCCN still has epirubicin in the regimens. And similarly, if you look at the European guidelines, which were also endorsed by the Japanese Society for Clinical Oncology, if you look at both in the early stage disease on the sort of left side and then the later stage disease on the right side, the preference is listed as ECX, and if a triplet, either ECF or a modification. So all the wisdom still says to do epirubicin. This slide has been shown a few times. Some arguments made when you look at 2 trials, the MAGIC trial and the French trial, which I'll show you next. One of them included epirubicin, the other one had epirubicin dropped. So that's the French trial. And when you compare the 2 together, though the MAGIC trial was significantly more, looking at the differences in chemotherapy regimens, a lower dose of cisplatin, which was just argued as a very toxic, a much more toxic way of giving cisplatin, and definitely a different distribution of the site of disease. And so there's arguments that you look at the 5-year survival and it looks similar between the 2, trying to do cross-trial comparison. There is clearly difference in the distribution of disease, and so it's probably not the fairest argument to make that those show that in a perioperative setting, epirubicin adds no benefit. I think this was not shown in any of the talks previously, which is the CLGB trial that tried to use additional chemotherapy beyond just a fluoropyrimidine in the postoperative setting after resection of gastric cancer. You can see here this was the original McDonald regimen, the most toxic way of giving 5-FU and leucovorin, the Mayo Clinic way, along with the variation is a continuous infusion of 5-FU with radiation, and instead of the Mayo Clinic 5-FU and leucovorin, giving ECF. And these are the eligibility criteria. Again, it was a postoperative regimen. There's no difference, so epirubicin didn't add anything here. And you can see that here in these numbers as well, both median and various landmark endpoints in terms of overall survival. And the reason off therapy is actually higher in the ECF arms, but the actual toxicities was a little better tolerated. Again, I'll admit it's the Mayo Clinic regimen of 5-FU and leucovorin, which is the most toxic way of giving it. But there's still some difference and some improved tolerance with the ECF regimen over Mayo Clinic 5-FU and leucovorin. So this is a variation of David's slide looking at the evolution of chemotherapy for advanced disease for gastric cancer. Again, initially with 5-FU, showing some improvement with the FAM regimen, then substituting methotrexate, and then ultimately the ECF regimen, and then the development of the variations of the epirubicin, platinum, and a fluoropyrimidine. So David pointed out the meta-analysis that argues for advanced disease for epirubicin. These are the 3 trials that went into the meta-analysis. So the first one, and admittedly the numbers are small, so this trial only has 60 patients in it, but it's looking at cisplatin 5-FU versus cisplatin 5-FU, not significant, but you can see, again, it's only 60 patients. Numerically, adding epirubicin had an improvement in 6-month survival as well as 1-year survival, in fact, doubling it, albeit only 60 patients. And then similarly, the trial from South Korea, which showed some modest improvement in median overall survival, 7.3 versus 8.5 months. Again, not significant, but a trial of only 120 patients. And this is the trial that was referred to that's not compared to a regimen without epirubicin, cisplatin 5-FU plus or minus epirubicin, because mitomycin is a substitute. And these are the data from that trial. And as David showed, this is the meta-analysis for that trial, which again shows that regimens that include epirubicin, albeit 2 of them, or 1 of them had another, was still a triplet, showed some modest improvement. In addition, there's this trial, which again includes mitomycin, but using pegdoxorubicin to Doxil as a comparison. And there does show a significant improvement with a pegylated anthracycline in metastatic disease as first-line therapy for gastric cancer, albeit again a small trial. Here's the REAL-2 trial that David showed. Again, shows that these regimens all have somewhere around 10 months. 10.5 months is different than 11.2 months. In fact, that's what gotten several of the late-line therapies for colorectal cancer approved, a 0.7-month difference. So there is still there. And I think the 11.2 is a real number because all the other trials that were shown have really consistently 11.2, 11.3 months as a fairly consistent for the UX. So one argument that can be made is maybe there are certain populations that should be treated with epirubicin and just how to figure out who they are. And I think that's where there's been really not as much work in gastric cancer. There is work in breast cancer. And so this is data from 5 randomized adjuvant trials in breast cancer that compared an anthracycline-based regimen to CMF. It's using a marker, topoisomerase 1 alpha, topo2 alpha, which is an enzyme required for DNA replication and a molecular target for anthracyclines. And you can see here in all these curves where the top curves looks at, and there's different alterations that can occur to topo2A. So it either can be amplified, it could be mutated, it could be deleted, and with any type of alteration, you can see that an anthracycline regimen is favored over CMF, at least in adjuvant breast cancer. How this applies to gastric cancer, I think, still not well studied enough. This is looking at various mutations that can occur, and topo2A can be certainly a target. So some of these older trials can certainly maybe go back and try to figure out which patients may benefit from an anthracycline. So in conclusion, anthracyclines have been integral in the treatment of esophagogastric cancers for 2 decades. There are clear alternatives that are active. So I personally don't use epi that much, but I want at least one person to say they do. Choice of therapy should be based on individual patient characteristics and choices. And again, trying to figure out how to personalize these individual therapies is maybe a reasonable approach. Thank you.